Hello, this is Shashank Saxena. I'm a clinical assistant professor of anesthesiology at University of Pittsburgh Medical Center and University of Pittsburgh School of Medicine. I have nothing to disclose, and we're going to talk about renal physiology. Kidney has several important homeostatic, hormonal, and metabolic functions that include maintenance of water and electrolyte homeostasis, regulation of acid-base balance in conjunction with the respiratory system, excretion of metabolic waste products, production of renin for blood pressure control, and erythropoietin, which stimulates red blood cell production in the bone marrow, conversion of vitamin D into active form for regulation of calcium balance. The blood supply to the kidney is by the renal artery, which is a direct branch of the abdominal aorta. Venous drainage is via a single renal vein to the IVC. These vessels enter the kidney via the hilum. An important thing to note is the right kidney has a longer renal artery, whereas the left kidney has a longer renal vein. This figure depicts the structure of the kidneys. It also shows the basic functional unit of the kidney, which is the glomerulus, the Bowman's capsule, and we're going to talk about that in detail in the following slides. The renal artery leads to This slide depicts the blood flow to the kidneys. The renal artery gives rise to interlobar arteries, which give rise to the arcuate arteries, the interlobular arteries, which go to the cortex, the efferent arterioles, which go into the glomerulus, the glomerular capillaries, the efferent arterioles, the tubular capillaries in the cortex, and vasa recta in the medulla, and then the venous drainage by the interlobular veins, arcuate veins, interlobar veins, and the renal veins. The total renal blood flow is approximately 1,000 mL per minute, about 20% of the cardiac output. Cortex is the least metabolically active and receives about 90% of the blood flow. However, the metabolically active medulla receives only 10% of the renal blood flow. The high cortical blood flow is required to drive the filtration of the plasma at the glomerulus at an adequate rate, that is, to provide an adequate GFR. GFR depends on the permeability of the filtration barrier and the net difference between the hydrostatic forces pushing the fluid into the Bowman's capsule and the osmotic forces keeping the fluid in the plasma, as depicted in the next slide. We're going to talk about autoregulation of renal blood flow. This slide depicts that the autoregulation of renal blood flow and GFR is done at a wide range of blood pressures, from 50 to 150 millimeters of mercury. Urinary flow is not autoregulated. However, there is a linear relationship between a mean arterial pressure greater than 50 and urinary output. The theories of autoregulation. The first theory that I want to talk about is the myogenic theory, which basically states that whenever there is an increase in blood pressure, the afferent arterioles stretch, which causes them to reflexly constrict and thereby decreasing the blood flow. The second mechanism is the tubulo-glomerular feedback, which is mediated by chloride ions. Whenever there is decrease in renal blood flow, there is decrease in GFR, which decreases the amount of chloride ions delivered to the juxtaglomerular apparatus. This causes afferent arteriole dilation. The decrease in chloride delivery to the juxtaglomerular cells also stimulates the production of renin, which produces angiotensin II, which causes efferent arteriolar constriction. Both of these will decrease the GFR. Here is the basic structure of the nephron. The nephron, as we all know, is the structural and functional unit of the kidney. There are about 2 million nephrons in each kidney. The nephron begin in the cortex, right here, dip down into the medulla, and then return to the cortex. So they start in the cortex, dip down to the medulla, return to the cortex, and then drain into the collecting ducts. The collecting ducts then descend towards the renal pelvis and empty urine into the ureter. The component of the single nephron include the renal corpuscle, which is right here. This leads to the proximal convoluted tubule, which leads to the loop of Henle. The loop of Henle has a thin descending limb, a thin ascending limb, and a thick ascending limb. The turn of the loop of Henle usually occurs in the thin segment within the medulla, and the tubule then ascends upwards toward the cortex, parallel to the descending limb. The loops of Henle run in parallel to the capillary loops known as the vasa recta. The loop of Henle then leads into the distal tubule. The end of the loop of Henle becomes distal convoluted tubule near its original glomerulus. The initial segment of the distal convoluted tubule lies right next to the glomerulus and forms the juxtaglomerular apparatus. The terminal portion of the distal tubule empties through the collecting tubules into the straight collecting duct into the medullary ray. The collecting duct system is under the control of antidiuretic hormone. When ADH is present, the collecting ducts becomes permeable to water. So it's important to know what structures are located where in a kidney. The cortex. The cortex contains the renal corpuscle, the proximal, and the distal convoluted tubules. The medulla and the medullary rays contain the loops of Henle and the collecting ducts. Throughout the length of the nephron, capillaries called peritubular capillaries lie adjacent to all sections of the tubules. They originate from the efferent arterioles and are important for solute transport throughout the tubule. The next slide depicts a very important functional unit of the kidney called the macula densa. Macula densa is a modified portion of the distal convoluted tubule. It is applied to the glomerulus between the afferent and efferent arterioles. Cells of the macula densa are chemoreceptors. They sense tubular changes in sodium chloride concentrations. The cells of the afferent and efferent arterioles in this section have modified smooth muscle that secrete renin. They also have baroreceptors and are innervated by sympathetic nerves. In the subsequent slides, we'll find out how the renin-angiotensin system works. Now we're going to talk about renal tubular reabsorption and secretion. This slide depicts the various sites of absorption, the sites of absorption of various solutes throughout the entire nephron. The major function of the proximal tubule is sodium reabsorption. Sodium is actively transported out of the proximal tubular cells at their capillary site by membrane-bound sodium-potassium ATPase. The resulting low intercellular concentration of sodium allows passive movement of sodium down its concentration gradient from the tubular fluid into the epithelial cells. Angiotensin II and norepinephrine enhance sodium reabsorption in the early proximal tubule. In contrast, dopamine and phenoldiazepam decrease the proximal reabsorption of the sodium via the D1 receptor activation, thereby causing diuresis, as we will learn in future slides. Sodium reabsorption is coupled with reabsorption of other solutes and secretion of H+. This mechanism is responsible for absorption of about 90% of the filtered bicarbonate ions in the proximal tubule. Water moves passively out of the proximal tubule along the osmotic gradient. The next portion we're going to talk about is the loop of Henle. With the exception of the ascending thick segments, the solute and water reabsorption in the loop of Henle is passive and follows the concentration and the osmotic gradients respectively. In the ascending thick loop of Henle, however, sodium and chloride are reabsorbed in excess of water. Moreover, sodium reabsorption in this part of the nephron is directly coupled to both potassium and chloride reabsorption. Unlike the descending limb, the thin ascending limb, the thick parts of the ascending limb are impermeable to water. As a result, the tubular fluid flowing out of the loop of Henle is hypotonic. And the interstitium surrounding the loop of Henle is hypertonic. Now we're going to go to the distal tubule. Sodium reabsorption of the distal tubule normally accounts for about 5% of the filtered sodium load. Sodium reabsorption in this segment is directly proportional to sodium delivery. The distal tubule is the major site of parathyroid hormone and vitamin D-mediated calcium reabsorption. The latter portion of the distal tubule is referred to as the connecting segment, participating in aldosterone-mediated sodium reabsorption. The cortical collecting tubule. This part of the nephrons contains two types of cells: the principal cells, which primarily secrete potassium and participate in aldosterone-mediated sodium reabsorption, and the intercalated cells of the eye cell, which is responsible for acid-base regulation. Because B cells reabsorb sodium via electrogenic pump, either chloride must be reabsorbed or potassium must be secreted to maintain electroneutrality. Aldosterone enhances sodium-potassium ATPase activity in this part of the nephron by increasing the number of open sodium and potassium channels. Aldosterone also enhances H+ secretion. The medullary collecting tubule courses down from the cortex through the hypertonic medulla before joining the collecting tubules from the nephrons to form the single ureter in each kidney. This part of the collecting tubule is the principal site of action of ADH, or also called antidiuretic hormone or arginine vasopressin. ADH stimulates the expression of water channel protein aquaporin 2 in the cell membrane. Dehydration increases ADH secretion, rendering the lumen membrane permeable to water. As a result, water is osmotically drawn out from the tubular fluid passing through the medulla, resulting in production of concentrated urine. So the next few slides do talk about the various sites of the various solutes that are reabsorbed or secreted in the different parts of the nephrons. And I'm going to quickly, we already went over them descriptively, so I'm just going to go over these slides quickly. As you can see, juxtaglomerular apparatus is the site of secretion of renin, collecting tubules, site of production of ammonia. The important thing I wanted to stress about in renal physiology is medullary oxygen demand. Oxygen diffuses from the descending to the ascending vasa recta within the vascular bundles, limiting the oxygen delivery to the renal medulla. In addition, the medulla suffers from unusually high oxygen demand related to tubular transport activity, where the medullary oxygen extraction approaches really 90%. Thus, the renal medulla is constantly on the brink of hypoxia owing to high demand and low delivery of oxygen, as you can see in this slide. Next, we're going to talk about hormonal regulation of extracellular fluid volume, the role of arginine vasopressin. Dehydration causes increase in ESF osmolality, causes the secretion of AVP, which is also previously known as antidiuretic hormone. This stimulates the absorption of water from the collecting ducts. AVP also makes medullary part of the collecting ducts permeable to urea so that urea can enter the medullary interstitium, allowing the maximum amount of water to be reabsorbed from the collecting ducts. Role of aldosterone: hemorrhage causes decrease in extracellular fluid volume, leading to the production of angiotensin II. Aldosterone is produced in response to angiotensin II, which leads to increase in sodium reabsorption in exchange for potassium and hydrogen ions. The resultant increase in plasma osmolarity leads to AVP production and water retention and normalizes the extracellular fluid volume. It is fair to say that arginine vasopressin regulates the extracellular fluid osmolality and the aldosterone regulates the extracellular fluid volume. Role of renin-angiotensin system: whenever there is overt hypovolemia due to hemorrhage, diuresis, sodium loss, or restriction, or covert like positive pressure ventilation, congestive cardiac failure, sepsis, or cirrhosis, renin production is stimulated. There is also decrease in renal artery perfusion pressure, which triggers baroreceptors in the efferent arterioles. Tubular glomerular feedback also plays an important role, whereas an increase in chloride concentration in the distal tubular fluid activates the cells of the macula densa, which triggers the release of renin from the efferent arteriole. Angiotensin II causes renal cortical vasoconstriction, predominantly at the level of the efferent arterioles. This acts to maintain the GFR in the phase of mild to moderate decrease in renal blood flow or the perfusion pressure. Angiotensin II, aldosterone causes aldosterone secretion from the adrenal cortex, AVP secretion from the posterior pituitary, and sodium chloride reabsorption from the proximal tubule, causing salt and water retention, as depicted in this slide. Opposing the renal vasoconstricted mechanisms are the renal vasodilator mechanisms, which are as follows. Atrial natriuretic peptide causes increase in GFR, vasodilation, inhibits renin release, blocks the reabsorption of salt and water from the distal tubule and the collecting ducts, opposes angiotensin II, and decreases aldosterone. Nitric oxide opposes angiotensin II, causes increase in sodium and water excretion. Prostaglandins oppose ADH, norepinephrine, and the renin, angiotensin, and aldosterone system. What are the tests that we need to order when we are evaluating renal function? A complete blood count, urine analysis, serum creatinine, urea concentration and clearances, serum electrolytes, pH and blood gas, and electrocardiogram. A note about creatinine. Creatinine is freely filtered at the glomerulus and is neither reabsorbed nor secreted. Therefore, serum creatinine measurements reflect GFR function, and creatinine clearance is a specific measurement of GFR. However, it's important to note that the serum creatinine concentration required 48 to 72 hours to equilibrate to a new level following a sudden renal injury and a change in GFR. Here is the formula depicting the creatinine clearance, which is important to calculate, especially in patients with renal dysfunction, so you can tailor the medication accordingly. An important thing to know is as long as the flow is maintained and perfusion pressure does not fall below the autoregulatory range during spinal and epidural anesthesia, there will be little change in GFR or renal vascular resistance. This slide depicts the site of action of various diuretics. As you can see, the osmotic diuretics like mannitol act at the level of the proximal convoluted tubule and the descending loop of Henle mainly. The carbonic anhydrase inhibitors like acetazolamide act at the proximal convoluted tubule. The loop diuretics like Lasix act at the level of the thick ascending loop of Henle. The thiazide diuretics act at the distal convoluted tubule, inhibiting sodium and chloride symport. The potassium-sparing diuretics like triamterene and amiloride and spironolactone act at the collecting duct. Spironolactone inhibits the aldosterone action at the collecting duct, causing sodium loss and potassium retention. These are the two most commonly used diuretics in anesthesiology. Mannitol. Mannitol is an osmotic diuretic. It causes urinary excretion of sodium, chloride, water, and bicarbonate. Furosemide or Lasix is a loop diuretic. It causes urinary excretion of sodium, potassium, and chloride ions. Mannitol is used for renal protection in cardiovascular surgery and trauma. It is also used for the treatment of intracranial pressure increase or increase in intraocular pressure. It may also be used for differential diagnosis of acute oliguria. Furosemide or Lasix is used for treatment of pulmonary edema. It can also be used for the treatment of increased intracranial pressure, especially in patients with head injury. Differential diagnosis of oliguria is also one of the reasons why Lasix is used sometimes. It is important to note that if mannitol is given in a rapid fashion, it can precipitate pulmonary edema and CHF. If given excessively, it can cause hypovolemia due to excessive diuresis. If you have disruption of the blood-brain barrier, it can cause rebound intracranial hypertension. Furosemide and Lasix can cause hypovolemia, enhance nephrotoxicity of aminoglycoside antibiotics, increase the plasma lithium level, and has also been implicated in hypokalemic, hypochloremic metabolic alkalosis. The first diuretic I'm going to talk about is carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors are drugs that inhibit carbonic anhydrase, the enzyme that helps in the conversion of H2 and CO2 to H2CO3. The net effect of these agents is that sodium and bicarbonate, which would otherwise have been reabsorbed, remain in the urine, resulting in alkaline diuresis. The most common carbonic anhydrase inhibitor used is acetazolamide, used in the treatment of glaucoma. Potassium-sparing diuretics are triamterene, amiloride, spironolactone, and eplerenone. Triamterene and amiloride act at the collecting ducts and directly inhibit luminal sodium entry, blocking this mechanism and resulting in potassium-sparing effects. In addition, H+ secretion is inhibited. Spironolactone and eplerenone. Aldosterone normally stimulates sodium reabsorption and potassium excretion by collecting duct. Inhibition of the aldosterone effect by these drugs causes mild natriuresis and potassium retention. It's important to note that hyperkalemia and hyperkalemic hyperchloremic metabolic acidosis are significant complications of injudicious use of potassium-sparing diuretics. Regulation of acid-base balance by the kidney is done by two main mechanisms. The first one is the reabsorption of filtered bicarbonate. Bicarbonate is the predominant extracellular buffer against fixed acid. The second is excretion of fixed acids. Reabsorption of bicarbonate is dependent on four important factors as depicted below: luminal bicarbonate concentration, potassium level, arterial PaCO2, and angiotensin II. An increase in any of these four factors can cause bicarbonate reabsorption increase. Increase in parathyroid hormone concentration also will decrease bicarbonate reabsorption. It is important to note about 85 to 90% of the filtered bicarbonate is reabsorbed in the proximal convoluted tubule. Excretion of fixed acids by kidney. Excretion of fixed acid occurs with different conjugate bases which are grouped as titrable acids, namely the phosphates, and non-titrable acids, namely the ammonium. Excretion of titrable acids has a limit dependent on the filtered phosphate load. However, the kidney can generate its own buffer, namely ammonia, allowing excretion of one hydrogen ion for nearly every ammonia produced. In the next section, we're going to talk about renal drug excretion. The three mechanisms of renal drug excretion are glomerular filtration, tubular secretion, tubular reabsorption. Glomerular filtration accounts for most of the drug excretion. Polar compounds account for most drug metabolites. Drug bound to plasma protein remain in the circulation. Only unbound drug is filtered as long as their size, charge, and shape are not very large. Tubular secretion. It's an active process since drugs are carried against a favorable chemical gradient from the capillary network into the tubule. Examples are penicillin, salicylic acid, indomethacin, thiazide diuretics. This mechanism is subject to competitive inhibition. It's independent of binding of drugs to the proteins, and excretion is independent about the urinary pH. Tubular reabsorption can be active or passive. Active tubular reabsorption is done for vitamins, amino acids, and electrolytes. Passive tubular reabsorption is done for filtered liposoluble substances. Total body water. The average adult female is 50% water by weight, while a male is 60% water. The difference due to females' additional adiposity. These differences are reduced with age as adipose tissue is reduced. The total body water is distributed throughout the body and can be thought as being different compartments. The compartments are separated from each other by membranes that regulate the flow of water between each compartment and thereby control the amount of water which can exist in each compartment. Intracellular fluid compartment is the largest and accounts for about 2/3 of the total body water. Includes all water and electrolytes within the cells. The extracellular fluid compartment includes all water and electrolyte outside the cells. This includes interstitial fluid, plasma, lymph, and the transcellular fluid. Extracellular fluids have high concentration of sodium, chloride, bicarbonate ions, and a lesser amount of potassium, calcium, magnesium, phosphate, and sulfate ions. Intracellular fluid has high concentration of potassium, phosphate, magnesium, and lesser amounts of sodium, chloride, and bicarbonate ions. Movement of fluid between compartments depends on hydrostatic pressure and the osmotic pressure, which regulates the movement of water and electrolytes from one compartment to the other. Urinary pH markedly affects drug reabsorption excretion because urine pH determines the ionization state of weak acids or base. Acidification of urine increases reabsorption and increases the excretion of weak acids, and in contrast decreases the reabsorption of weak bases. Alkalinization of urine does the opposite. Now we're going to talk about dopaminergic system. There are two kinds of dopaminergic receptors, DA1 and DA2. DA1 receptors are found in the renal and the splenic vasculature and the proximal tubules. Stimulation of these receptors activates CAMP, renal vasodilation, increased renal blood flow, and GFR, natriuresis, and diuresis. DA2, presynaptic terminal of the postganglionic sympathetic nerves. Stimulation inhibits norepinephrine release and promotes peripheral vasodilation. The endogenous dopamine acts as a natriuretic vasodilatory factor. It also opposes the anti-natriuretic effects of norepinephrine, angiotensin II, and aldosterone. The two main dopaminergic drugs that are used are dopamine and phenoldipan. Dopamine is a non-selective DA1, DA2 agonist with increasing doses action secondary to stimulation of adrenergic beta-1 and alpha receptors. The effects are as follows. Low-dose dopamine at about 3 mics per kilo per minute causes mild renal vasodilation. At 1 to 5 mics per minute, there's a twofold increase in sodium excretion. 7.5 mics per kilo per minute increase in systolic blood pressure. There are considerable controversies about renal dose dopamine. Before 2000, the renal dose dopamine was used widely as it was thought to improve renal blood flow and urinary output. In 2001, the landmark article by Dr. John Kellum at the University of Pittsburgh refuted the widespread use of dopamine, stating the use of low-dose dopamine for treatment or prevention of acute renal failure cannot be justified on the basis of available clinical evidence and should be eliminated for routine clinical use. Although dopamine increases the outer medullary flow in the hypovolemic animal, it fails to improve the outer medullary dysoxia. Low-dose dopamine can increase cardiac contractility and systemic resistance, but also has been reported to be associated with gut and tissue necrosis. The maximal renal effect of low-dose dopamine is temporary and variable. Renal effects can decrease with time. And as stated before, it does not prevent or treat acute renal failure. Therefore, dopamine infusion has not been shown to prevent acute renal failure, avert the need of renal replacement therapy, or reduce mortality, and should not be administered solely for renal protection. Phenoldiazepam, that's the second drug we're going to talk about. Just hold like this. It's okay. Phenoldiazepam is a selective dopamine 1 receptor agonist. The selective dopaminergic action of phenoldiazepam appears to improve renal performance in situations of reduced renal blood flow such as severe hypertension. These effects are mediated by increase in renal blood flow to both cortex and medullary regions. It also causes diuresis and natriuresis. Phenoldiazepam should not be used as a prophylactic measure to prevent acute renal failure in high-risk cardiac surgical population. Among patients with acute kidney injury after cardiac surgery, phenoldiazepam infusion compared with placebo did not reduce the need for RRT or risk of 30-day mortality and was associated with an increased rate of hypotension. So how to maintain renal blood flow and renal perfusion pressure? The initial approach should be intravascular volume expansion to reverse hypovolemia. Inotropic and vasopressor therapy may then be initiated for management of low cardiac output and systemic arterial hypotension respectively after treating hypovolemia. The optimal therapeutic range for systemic arterial pressure for renal protection has not been established. A minimum mean arterial pressure of 65 to 75 mm of mercury is often targeted in clinical practice. Which medication to choose for improving blood pressure? Norepinephrine versus phenylephrine. In different studies, it has been shown that phenylephrine replacing norepinephrine in a series of septic shock patients negatively affected renal function, as indicated by a decrease in creatinine clearance compared with the norepinephrine administration. However, phenylephrine does not compromise splanchnic blood flow. Breslow and colleagues reported no differences between phenylephrine and norepinephrine in terms of splanchnic oxygen supply. Phenylephrine dosages higher, that is 220%, than those of norepinephrine may be needed to maintain predefined threshold mean arterial pressure. It has also been shown in multiple studies that norepinephrine is superior to dopamine in restoring blood pressure and urinary output in hyperdynamic hypotensive septic shock. Tachycardia, which is another adverse effect of dopamine, together with vasoconstriction, can lead to increased cardiac oxygen demand and decreased oxygen delivery and may trigger myocardial ischemia and arrhythmias. So in conclusion, a mixed alpha-adrenergic and beta-adrenergic agent, when given to increase or maintain mean arterial pressure, may be better than a sole alpha agonist. Norepinephrine is therefore an excellent first-line vasopressor agent. There is no firm evidence to suggest that the drug compromises renal, hepatic, or gastrointestinal blood flow when used to treat arterial hypotension in doses of 0.01 to 3 mics per kilo per minute. Vasopressin and terlipressin may be useful agents in treatment of postoperative catecholamine-resistant vasodilatory shock.